Good evening again, everyone. Thank you for joining this men's health webinar. We will start with just a few housekeeping items, and then I'll introduce tonight's speakers. First, your participation in tonight's webinar is completely anonymous to other attendees. No one can see your face or your name, and any comments or questions can only be seen by myself or our speakers. If you wish at any time throughout the presentation to ask a question, please type it in the chat box at the lower part of your screen, and we will have a Q&A portion at the end of the presentation to address all these questions. Our presentation tonight will last for approximately 1 hour and will be presented by Dr. Eric Kirshenbaum and Dr. Marc Nelson of UroPartners. Dr. Kirshenbaum completed his medical education at University of Illinois Chicago, then completed his residency in urology at Loyola University Medical Center, followed by a fellowship in the men's health and reconstructive urology. Dr. Nelson completed his medical education at the University of Virginia School of Medicine, and then also completed his urology residency at Loyola University Medical Center. Both Dr. Kirshenbaum and Dr. Nelson focus on general urology as well as reconstructive needs, including erectile dysfunction and urinary incontinence. Thank you for joining us tonight, and now I'll turn it over to Dr. Kirshenbaum to get us started.
All right, thank you. Thank you for the introduction, and I'd like to just welcome everybody. I'm very excited as this topic is near and dear to Dr. Nelson and my heart. And the goal for tonight is just really education. And tonight, the topics that we will be focusing on is erectile dysfunction and stress urinary incontinence. As you can see here, this is us. These are our bios. Dr. Nelson and I actually trained together at Loyola, and we both have a particular interest in men's health and really the restoration of the male as he ages. As you can see on the bottom, you can see our contact information, which will also be sent out at the end of our talk. We're at all 3 offices, and we're happy to see anybody who would like to follow up for an appointment after this webinar. So I'll be talking specifically about erectile dysfunction and the various treatment options that you have. We'll be talking about what is erectile dysfunction, what kind of people get erectile dysfunction, what causes it, and then we'll also talk about the various treatment options that you have as a patient. So what is it? How do we define it? So the definition of erectile dysfunction is the inability to achieve or maintain an erection firm enough to have sexual intercourse. It is way more prevalent than most people think. 1 in 5 Americans greater than 20 years old will experience ED in their lifetime. And more than half of men over 40 have some degree of erectile dysfunction. And it affects nearly 40 million American men. So it is everywhere. It is extraordinarily prevalent. It is often a disease process that's hidden and goes untreated for far too long. So our job is to educate you on, like I said, what it is and what your treatment options are. So just a little tidbit about the anatomy of an erection. So an erection involves nerves, arteries, veins, and it is a complex process for a male to go from the flaccid state to an erect state. And our job is to kind of restore that physiological function, whether it be through medications, through injections, or through penile prosthesis, which we'll talk about. So what are the causes? The top 3 causes are vascular disease, which could be related to hypertension. It is diabetes. It is various medications that men could be on. It could be less commonly people who've had pelvic surgery or trauma, who've had treatment for prostate cancer. There are neurologic causes, endocrine causes, and then a small percent of the other causes. And ED can be a result of or a precursor to prostate cancer treatment. And then also specifically precursors for diabetes and heart disease, something that I'll go into detail about. When a man has erectile dysfunction, it really affects everything in every part of their life often. It affects their mental health. It affects their general health perception, their functioning in society, their social functioning, their vitality, their physical functioning. It could cause physical pain. It could affect people's relationships. And our goal is to restore that quality of life that has been taken away. So I want to talk specifically about erectile dysfunction and diabetes because they are directly related. So according to the 2012 census, 15.5 million men in the US have diabetes, so it is extraordinarily prevalent. And erectile dysfunction occurs 10 to 15 years earlier in men with diabetes. So it's something that this is a population that we really need to watch out for because it goes untreated and it occurs very often in the very early in the disease process. We know that ED is less responsive to the oral treatments in patients with diabetes. We know that 1 in 2 men with diabetes have sexual trouble caused by their disease. We know that in men with diabetes, ED is more severe and associated with a poor quality of life. So this population, this diabetic population, is one that suffers silently and one that, like I said, we really have to pay attention to and catch early and for early intervention. So just a little bit about how diabetes affects erections and the nervous system in general. So diabetes and conditions related to diabetes can damage the nerves and tissues associated with achieving and maintaining a good erection. 60 to 70% of people with diabetes have some sort of nerve damage which directly affect their ability to achieve an erection and maintain an erection. It affects the blood vessels that supply the penis and is directly related to the ability to have an erection. So oral medications require the nerves to be healthy and also require the blood vessels to be healthy. And that's why in diabetic men, the pills often do not work as well. So here are some factors that may increase erectile dysfunction in men with diabetes. It's our older population. It's our population who've had diabetes for a longer period of time, who've had a period of time in their life where they've had poor glycemic control. It's those patients who've had what we call microvascular complications, which is issues which you could see in your hands and your feet. It's those on other diuretic medications, and then also men with with diabetes, as well as heart disease or cardiovascular disease. So I want to talk specifically about erectile dysfunction and cardiovascular disease because these two disease processes are also interconnected. We know that erectile dysfunction is often a red flag or warning sign to our patients that there might be a more serious issue underlying their ED. It's almost a silent indicator of coronary artery disease and increases your risk for having a heart attack down the line. So our goal is to catch these patients early. And those patients who come to our clinic with erectile dysfunction, we connect them with our cardiologist in order to have early intervention. We draw their lipids to make sure that all of those are taken care of. So it's really something that we got to watch out for is the development of cardiovascular complications in this population. Like I said, ED often presents before symptoms of heart disease, and it can affect the small blood vessels ranging that affect your erection, but also can affect the larger blood vessels in your body that could cause heart attack, stroke, and even leg pain while you walk. So how do we intervene? What kind of things can we do to reduce our risk in this patient population? We can make healthy lifestyle choices, change our diets, increase our exercise, get on the weight loss plans, quit smoking is a big one, and then overall reduce stress because stress in general can really affect both heart disease and erectile dysfunction. So one topic specifically that I want to talk about tonight is erectile dysfunction and prostate cancer treatment because those two things go hand in hand. When you have treatment of your prostate cancer, the nerves that provide the necessary stimulation for an erection often are involved in our treatment, whether it be surgery or radiation. those nerves are directly related to our treatments and can often be damaged. And what that does, it affects a man's ability to get an erection either on a temporary basis or on a permanent basis, unfortunately. So overall, in this population, erectile dysfunction affects 25 to 75% of men, which is a large number. And this also occurs for any intervention that we do, whether it be radiation, which it can affect up to 50% of men, and after we do a robotic prostatectomy, which erectile dysfunction happens in 10 to 46% of men. So this population, obviously, we treat prostate cancer as urologists, and so we want to make sure that when we do these surgeries or have to undergo these treatments, that we are there for our patients to restore their function after that. Prostate cancer is not the end of the road in terms of function, and our goal as urologists and men's health specialists is to restore all that function that had been lost in these various treatments. Now, erectile dysfunction and Peyronie's disease, I want to just touch on very briefly. So Peyronie's disease is the development of scar tissue, which causes an abnormal bend or curvature in the penis, and it can cause painful erections. It can really affect a man's ability to have intercourse. They often have difficulty achieving or maintaining erections, and it can cause a great deal of stress and anxiety with your partners. So there are various treatment options for men with erectile dysfunction and Peyronie's disease. There's medications like Xiaflex, which is an injectable therapy that we do into that area of curvature, that plaque area. There's penile plication, where we straighten the penis with stitches. There's grafting procedures. There's penile implants that we can do. There's a variety of procedures and treatment options available for these men. And we also have a particular interest in this disease process, and we're happy to talk more about Peyronie's if that's something that people are interested in. So I've talked about the issue and the problem at hand, and I guess the best thing that I can do now is provide some solutions to restore those functions that have been lost. So what are the treatment options? So first of all, who can treat erectile dysfunction? So your general doctor can do a great job treating. They often are the ones that will be the first to prescribe the medical treatment options, your Viagra, your Cialis. The second is a urologist, and that's what Dr. Nelson and I, we specialize in both the medical and surgical management of erectile dysfunction. And then you have your prostatic urologist, and those are people who are specifically trained in men's health, in erectile dysfunction, and who perform penile implant surgery, which Dr. Nelson and I both do. So what is the gamut of treatments? So we talked about oral medications, which I'm sure a lot of you have tried. Then you have injection therapy, where you inject medication into the erectile bodies of the penis, which are able to then achieve an erection. You have a penile implant, where it's an implantable device all on the inside, where you can, we'll talk more in detail, where you can inflate and deflate as needed. You have a vacuum erection device, which is a vacuum that we'll talk about. And then you have a urethral suppository, which is a little seed that you could put at the tip of the penis to achieve an erection, with a similar medication to the injections. So how do the oral medications work? Without going into too much detail, they increase the blood flow to the penis. They improve the ability to obtain and maintain an erection through intercourse. It does require some sort of sexual stimulation. It has to be planned for, so it usually is taken 1 hour before any sort of sexual activity. It typically works for up to 4 hours, it typically works for up to 4 hours. It's not to be taken more than once a day. And then some oral medication efficacy can be affected by food, depending on which particular medication you're taking. And now, how effective are they? How many patients start it and continue on on the oral medication. In studies, the effectiveness is 50 to 85%. However, half of men with erectile dysfunction after prostate surgery give up on the pills. And then men with diabetes are 1.5 to 2 times more likely to move on to other treatments. So what are some of the side effects to the medication? A lot of patients will describe headache, facial flushing, some stuffy nose, and they can also get a little bit of upset stomach. We have to be careful in patients who have heart disease, who have a history of stroke or low blood pressure, and patients who have liver or kidney problems. That's not to say that if patients have those issues, we cannot prescribe those medications, but we have to be careful, and we counsel all patients on that. So some cautions for patients who do go on the oral medications. You have to talk to your doctor if you have any heart disease. If you're on an alpha blocker, Flomax, which is Flomax or tamsulosin, which a lot of you are on, you should be able to take it, but it has to be monitored closely. And those patients who are taking nitrates, we have to talk about whether you'd be a candidate for these medications. So a little bit about the vacuum device. What is it? It's a hollow tube that you place your penis in, and it's either battery powered or you can pump it yourself, and it creates a vacuum. It pulls the blood into the penis, and then you put an elastic tension ring to keep the blood there. A lot of patients do find this fairly cumbersome. While it is effective at getting an erection, a majority of patients, up to 86% of patients, go on to various other treatments because of how cumbersome it is, or the side effects, or just the discomfort associated with the vacuum device. Then you have your urethral suppository. And what that is, like I said, it's a small seed with medication in it that you put at the tip of the penis. You should achieve an erection between 5 to 10 minutes. It is about 50% effective, so not great. And 50% of men don't continue this therapy at 6 to 8 months. The most common side effects are pain in the penis or the urethra, burning. It can cause some low blood pressure, and also can cause some dizziness. I found recently that the availability and the cost of the urethral suppository has inhibited a lot of my patients who are interested in this from getting it. So it's actually pretty hard to get right now. The most common reasons for discontinuation is an insufficient erection or urethral pain and burning. So then we go to our injectable therapies. So how does it work? What we do is we inject medication directly into the erectile bodies. The onset of erection is typically at 5 to 20 minutes. And, excuse me, and it is fairly effective at 60%. We're satisfied and continued its use. Despite these success rates, in a recent study, only 20% of patients continue this type of therapy long term. The most common side effect is penile pain. You can get some scar tissue. There is a small risk of a prolonged erection. And then you can also get a hematoma, or what we call, or a little blood collection under the skin. The most common reasons why people stop using the injection is that their erection is not satisfactory enough, pain, or people just don't like using needles in their penis. So then we go on to the penile implant. And what this is, it is a pair of cylinders that you place into the erectile bodies. A pump is placed inside the scrotum, and a reservoir is buried in the lower abdomen. And what you do is, by squeezing the pump, it moves the fluid from the reservoir into the cylinders to produce a rigid erection. And you're able to, when you're not using it, you're able to deflate with a button that's on the pump, and the penis returns to its normal, flaccid, natural-looking state. This is a fairly effective option. 98% of patients reported that they had a excellent or satisfactory erection. And at 7 years, 94% are still using their device and have not had any sort of revision. The common side effects that we worry about is postoperative pain. Anytime you insert a mechanical device, there's a risk of malfunction of that device. And then you also, what we worry about is infection. So I just wanted to, if this works, show a short demonstration of what the device looks like and what the surgery is like. So as you can see, everything is concealed on the inside of the body. And this simply shows the fluid dynamics of fluid going from the reservoir into the cylinders by using the pump. And this is just a demonstration of the fluid going back into the reservoir from the cylinders. So what are the benefits of a penile implant? It is designed to be a permanent solution for erectile dysfunction. It is a more spontaneous erection because you don't have to worry about injections or pills. The erection lasts as long as you would like. Everything, like I said, is contained within the body. There is a high patient and partner satisfaction. It does not interfere with any ejaculation or orgasm. It has been around for a very long time, 40 years, and nearly 500,000 patients have been treated with a penile implant. Just a little bit about insurance coverage. It's not, insurance coverage cannot be guaranteed. Every insurance company is different. A majority of insurance companies do cover it. However, individual coverages may vary. We've had a lot of success with private insurances and Medicare. We work with patients, the insurance companies, to check with for coverage. We work with, like I said, we work with patients who are having issues, and if to do our best to try to get coverage for this. Like any other surgery, a penile implant, there are risks involved. There is, like I talked about, mechanical failure, bleeding, infection, pain. Some patients are just not a candidate for this given various other medical problems that they may have. So in conclusion, the one thing that I want you to walk away from is I don't want to sell you anything. Everybody's treatment journey is different, and our goal is to tailor your treatments to your needs, to your partner's needs, in order to come up with the best solution for you and for kind of your needs. We know that erectile dysfunction is very common, and it is associated with very common diseases like heart disease and diabetes. There are a variety of treatment options. A penile implant can offer a permanent solution, but we really want to work with you and your partner in your goals and your needs in coming up with the appropriate treatment plan. And you can talk to your ED specialist or find an ED specialist at edcure.org if you're interested in learning more information, or I'm happy to see you in clinic. So I'd like to turn it over to my colleague. We're going to switch places because we're in the same office right now. Dr. Nelson.
Thank you, Dr. Kirshenbaum. I want to start out by thanking everyone for coming tonight. Dr. Kirshenbaum and I are both passionate about sexual and urinary health for men. And I think one of the issues with treating it is that there is an unnecessary shame and barrier to entry to treatment. So maybe something that's nice about the pandemic and doing a virtual talk is that more of you can anonymously log on and begin to learn about treatment options and really get the ball rolling and get some help. So I'll be talking about male stress urinary incontinence. We'll discuss what it is, who has it, and what can cause it. The definition of male stress urinary incontinence is it's also known as bladder leakage. And stress urinary incontinence, or SUI, is when the urinary sphincter is damaged or weakened and it cannot squeeze and stop the urine from flowing out of the body when you laugh, lift, walk, bend, push, pull, move, hit a driver, etc. How prevalent is stress urinary incontinence? Studies have shown that after prostate cancer, which will be the vast majority of the men that we're speaking about, that as many as 50% of men report immediately following surgery. And most of these men will heal within the first couple of weeks to months following surgery. But roughly 9 to 16% of men will have persistent, bothersome stress urinary incontinence at 1 year following surgery. Worldwide, this equates to about 500,000 men suffering from stress incontinence. A bit about the bodily process. So here you see a cross-section of a male. If you can imagine urine flowing into the bladder from kidneys above the bladder, the urine is typically stored in the bladder until you're in the bathroom ready to urinate. Part of the urethra is surrounded by muscles called the sphincter muscle. And these muscles squeeze tightly on the urethra, which is the tube that delivers urine out of your body. The sphincter muscles remain contracted in order to keep urine in the bladder and results in continence. When the sphincter muscles relax, urine is then able to exit the body via the urethra. There are several common causes and comorbidities associated with stress incontinence. Most commonly in men, prostate cancer surgery or radiation are culprits or involved in the process. But other things that can cause incontinence are neurologic disorders, surgery for an enlarged prostate, external beam radiation, and pelvic trauma. As Dr. Kirshenbaum mentioned before, with erectile dysfunction, urinary incontinence really goes beyond the leakage of urine into a pad or diaper. It can have conscious or subconscious effects on your life. Some men are subconsciously avoiding social interaction or leaving the home or mapping out where the bathrooms are on their route. And it's not until there's some treatment and alleviation of the symptoms that they start to realize what they had been living with. So stress incontinence is a little bit more streamlined than erectile dysfunction, meaning there are fewer treatment options. So we'll get into those now. Let's run the numbers. So in the United States, about 180,000 men are diagnosed with prostate cancer a year. Around 70,000 of these men will have prostate cancer surgery. If we say roughly 9 to 16% of men have issues with incontinence, that means 7,000 men in the United States per year have new stress incontinence. Stress incontinence is a well-known side effect of prostate cancer treatment. Anytime a urologist or oncologist discusses the treatment for prostate cancer, they will be discussing the possibility of stress incontinence. As mentioned before, almost all men will have some form of incontinence immediately following surgery, but most of those men will improve throughout the first year. There are a subset of patients that do not. So how do we treat stress incontinence? First off, who can treat stress incontinence? Dr. Kirshenbaum and I both treat stress incontinence, but in general, a urologist, and specifically a urologist with a specialty in prosthetic or implant urology, would be who you'd want to see for stress incontinence. If you came into our clinic, we discussed conservative measures and then also surgical measures. The conservative measures treat the symptom primarily. And so we would discuss things like reducing the amount of fluid intake you have, planning your bathroom breaks and timed voiding. There are some pelvic floor and physical therapy interventions that can also help. And then a majority of the talk will be about things that help men cope with their incontinence. So pads, diapers, external or internal catheters, or clamps that go across the penis. Now, while these options work for some men, there are major drawbacks. Pads, the cost of pads add up. They are sometimes covered by insurance, but not always. And if not, they can exceed $7,000 a year. In addition, pads can be odorous, bulky, maybe not aesthetically pleasing to you. Catheters, internal catheters can be discreet and go under your clothing, but they are, when used in a long-term fashion, are a risk for infection as well as some other side effects. And then a penile clamp is the clamp that goes across the penis. It works in some men. We don't use it very often, but it's also an option. This can cause erosion and pain over time. There are more long-term treatment options, which both Dr. Kirshenbaum and I are passionate about. For men with moderate stress incontinence, there's a procedure called a male sling. This is essentially like a hammock for the urethra, and it supports the urethra to better control the urine. Studies have shown that it's most effective and most appropriate for men with mild to moderate incontinence. It's made with a soft mesh material that's completely concealed within the body. The artificial urinary sphincter is another implantable device that we do, and this replicates the function of the sphincter that we talked about before. This can treat all levels of stress incontinence, and it's made from 3 small connected components that are completely concealed in the body. There's a cuff that goes around the urethra, a control pump that is hidden next to your testicles within your scrotum, and a pressure regulating balloon, which would be in the abdomen. Some benefits of the male sling are that it is minimally invasive. The recovery is shorter than with a sphincter, and normal activities can be resumed in 1 to 2 weeks following surgery. There's no interaction with the device. Once it's in, you don't necessarily have to think about it at all. And it can help restore normalcy and renew confidence. The artificial sphincter mimics a healthy sphincter, and it allows you to urinate when desired. So a male will typically go to the urinal or to the bathroom and deactivate the cuff, and then we'll have flow of urine. So mimicking a normal bodily function. This can treat all levels of incontinence, and it's entirely undetectable to others. Here we have a short animation. So again, we have the same patient. This time, you can see the cuff around the urethra, which is the tube that travels through the penis. The pump is located next to the testicle in this case, and the pressure regulating balloon is up in the abdomen. Here you can see the cuff reinflating after deflation. So for the men who are here tonight, we don't need to say this, but if you are bothered by your leakage, take action, restore normalcy. All of you have already begun to seek out answers and try to get some help. Speak with your local urologist, come to our clinic and speak with us. You want to keep track of how often you're leaking, how many pads you're using, the type of pad you're using, and having this information handy can help us assess what treatment might be best for you. For more information, you can go to fixincontinence.com. Again, as with erectile dysfunction treatments, insurance coverage cannot be guaranteed, but Medicare and most private insurance companies cover these procedures that we're speaking about. So our office definitely will work with all patients to make sure that any treatments we prescribe are mutually agreed upon and affordable for the patient. So in summary, male stress incontinence is a known side effect of prostate cancer treatment, and there are a variety of treatment options. Coping short-term options can be expensive over time and uncomfortable, and a sling or artificial urinary sphincter can be a more permanent solution for incontinence. So talk with your urologist, continue to explore your options, and we're happy to see you all.